All right, I think we can get started. Thanks everyone for coming. This is an installment of the New York City Data Science Seminar Series, which is a quarterly series we have between Columbia, Cornell, Facebook, Microsoft Research, and NYU. So we have talks about every 3 months, and the idea is to bring together sort of the broader data science community. I'm very happy to have Ziad Obermeyer here. He's sort of uniquely positioned to talk about the intersection of machine learning and medicine because he himself is a practicing physician who also happens to know about as much machine learning and statistics as most statisticians and machine learners that have met. So I'm really glad to have him here. He is currently an associate professor at the School of Public Health at Berkeley. He has his medical degree from Harvard Medical School, and before that he studied history and philosophy of science at the University of Cambridge. He has a whole bunch of distinctions and awards, and I won't embarrass him too much by listing them all because I'm too excited to see us talk about racial bias and predictive healthcare, so I'll let you take it from there.
Thanks so much, Jake, and thanks for having me. Just make sure I can have a leash that's loose enough here. I was asking Jake if this was going to be an economics-style audience or a regular audience, and so I'm used to presenting to economists, which is to say, please don't hesitate to interrupt me aggressively and often as I talk to you about dissecting racial bias in an algorithm. So I think just by way of introduction, the general tone of the conversation around machine learning and medicine is extremely optimistic. And as a disclaimer, I share a lot of that optimism. I think that there are a lot of fantastic ways that algorithms are going to completely transform and improve medicine. At the same time, I think it's important to be conscious of the fact that these tools can also do harm. And I do remember taking that oath, and that's not something we're supposed to do. And so I'm going to tell you about one real-world use case where I think an algorithm is, because it incorporates racial bias, actually doing some harm in society in a way that's affecting important decisions for millions of people. And I'm going to tell you a little bit about the way we diagnosed that problem, which is by virtue of having access to a fairly unique data set that, unlike a lot of studies of racial bias, audit studies of algorithms that are in the world that are widely deployed, we have access to a lot of data, not just about how the algorithm works, but also the character and the mechanisms by which the bias gets introduced and reproduced in that algorithm. And that's, of course, what lets us design a solution that I'll also be curious to get your thoughts on. So I think if you step back and look at this kind of, again, very optimistic view of what medicine is, of what machine learning is going to do for medicine, you know, on the horizon, there are some really amazing looking tools. And so this is a paper that came out in Nature 2 years ago that inputs a picture of different skin findings and outputs the probability that something is a very serious skin problem like a melanoma, or something much more benign. And I think these algorithms, this is just one of many algorithms that, you know, is coming. And I think these are very much going to be part of the conversation in medicine. And as we look ahead to how that is going to play out, you can imagine that an algorithm that literally looks at the color of someone's skin might run into some problems around its performance in different racial groups. This was not mentioned in that paper, incidentally. And so, putting all that aside, we're actually going to talk about a completely different kind of algorithm today. So it's not something that takes in some high-dimensional signal and scrutinizes it for things that doctors can't find. This is actually something that is already deployed very, very widely in the healthcare system and affecting many, many patients every year. And rather than a kind of medical algorithm per se, this is something that's used in the policy context of medicine. So this is how administrators and people who do population health management make decisions. And the way to think about why now and why this is kind of already so widely deployed is that in the setting of the Affordable Care Act, Obamacare, the incentive set for all of the actors in the healthcare system completely switched. And so rather than a model where individual patients are being treated one at a time in a fee-for-service model and the revenues captured through that interaction, health systems and hospitals are increasingly incentivized to manage whole populations of patients, like at very large scale. And so you can see how that's going to be a setting where algorithms can flourish and can both add a lot of value and do a lot of damage. And so the particular algorithm that we're going to talk about is targeting a particular problem that I think everyone would agree is pretty widespread, which is how we handle very complex patients. So I think everyone who's had any interaction with the healthcare system knows that if you have a simple problem, chances are things will go well. If you have multiple chronic conditions, you're on many, many different medications, you have many doctors who are giving sometimes contradictory recommendations, you have to get appointments with lots of different specialists, things go wrong and balls get dropped, and that ends up leading to a lot of bad outcomes. Emergency visits, hospitalizations, as your health deteriorates and you get kind of lost in this maddening shuffle. That, in fairness, is partially due to medical complexity, but also due to administrative complexity in our healthcare system as well. And so there's been a lot of thought over the past 10 years around how we might be able to redesign the way these kinds of patients interface with the healthcare system and improve the way that works. And so the single thing, if you look kind of across every healthcare system in the US, almost every single one has invested pretty heavily in what's called care coordination programs or high-risk care management. It goes by lots of different names. The basic idea is that if you're one of these very high-cost, high-complexity patients and you have a problem, they just want you to pick up the phone. So there's a dedicated phone number. You can think of it a little bit like your Premier 1K number, or like it's a VIP program for people who really need help. And you're incentivized to just call whenever there's a problem, so have a low threshold for calling this number. And when you need help, they'll basically identify problems and do the triage and do their best to fix the problem. So there's a staff of trained nurses who are around to kind of be the air traffic controller. So they have extra slots that they set aside with primary care doctors. They will fill your prescription. If you run out, they'll kind of do all this stuff. They'll reconcile all the prescriptions that all of your different doctors are giving you and make sure there aren't interactions or kind of things that are going to adversely impact your health. And so overall, people find these things incredibly helpful because it's very hard to navigate a complex medical system. And so the evidence on these programs is generally positive in the sense that while some people debate how much of an impact on kind of the bottom line they have, patients really like them. And they do seem to find health problems before they get bad. And so if you have if your blood pressure gets out of control, before you go into heart failure and need to get hospitalized, they'll adjust the dose of your medication and prevent that hospitalization. And so that's the mechanism by which it's thought that small problems get nipped in the bud before they turn into big problems that require hospitalizations and procedures and things like that. And so it just turns out that these programs deliver both better quality and lower cost in a way that's good for the patient, but it's also good for the healthcare system because it cuts down on these burdensome high-cost events that are also causing costs at the healthcare system level to spiral out of control. So you can see how algorithms would be very useful here because these programs are expensive. So it's like dedicated nurses, like nurse practitioners who are trained. It's extra appointment slots, which is also a very valuable commodity. It's a lot of stuff, and that stuff is expensive. And so the targeting of those programs is critical. You cannot do this for everyone. This is a VIP program. Not everyone can be a VIP, unfortunately. And so that's where healthcare systems are using algorithms to do that targeting. And so you can take these industry estimates with a grain of salt, but the industry, the analytics healthcare analytics industry estimates that about 150 million patients every year are screened through an algorithm as part of the decision making to target them with one of these programs or not. We're going to be talking about the single largest one that's being used. So this alone is estimated to be used for decision making for 70 million people. And the goal of these algorithms is generically, as well as this is a kind of quote taken from the manufacturer, is to target patients with complex health needs and to flag them for intervention before their health becomes catastrophic. And so the specific thing that the algorithm we're going to study does is it's going to look ahead to next year's costs and predict those using data from this year. And it's going to do that largely with insurance claims type data. So this can be from Medicare, this can be from commercial insurance, but it's the kinds of data that are generically available. Some of them use electronic health record data, but the norm is just to use insurance claims data. So maybe I'll stop there. Any questions? Yeah, it's usually the healthcare systems themselves. So, like the New York Presbyterian Accountable Care Organization would buy the algorithm from a commercial manufacturer. And then there are different arrangements that are possible, but those algorithms are then used to generate predictions for patients within the NYP system.
So they are not standardized?
Say standardized in what way?
Are they standardized, like what these vendors offer to the healthcare systems?
No, they're just commercial products. There's there's no regulation or kind of standardization.
The data used is given by the hospital who takes.
Yes, exactly. Yeah, because it's you're generating predictions for your own patients. Yeah, maybe. I'm sorry.
It's not pre-trained or anything.
Let me. I'll tell you a little bit about this particular algorithm in a second. Any other questions to? Yeah.
So just a quick question. So, is there a legal framework that prohibits HMOs from discriminating based on something like protected class?
Yeah. So there are a lot of regulations around the provision of health insurance and what you can and can't take into account in denying coverage. Here we're largely working within the hospital systems themselves, and so a lot of those regulations don't apply. They don't map precisely onto this setting. Okay. So let me. I'll tell you a little bit about our algorithm in particular, and then please let me know if there are any more specifics I didn't cover. So this algorithm is, it's trained on a very large national data set that belongs to the company that makes the algorithm. And so that's millions and millions of people across the country. It's then applied to patients who are in a primary care practice at an academic hospital that we partnered with to study. And so all the data I'm going to show you are from about 40,000 patients. 12% of them are Black. We're going to be focusing mostly on Black-white cost differences. We have results for other races that I can tell you about once we have the big picture. And I think what makes this data set unique is that we have a lot of data on the algorithm that are because a lot of the algorithms that are deployed at scale, not just in health, but in the legal system, in credit rating, et cetera, are proprietary. It's very hard to get access to already the predictions, but the objective function, the data that goes into it, all those things are just really hard to get. And I'll just say this as like one plug for working in health for those of you who are marginal between working in health and working in some other high impact social area. If you can convince a healthcare system to give you access to the data, these data are just sitting on everyone's computer system. So we just kind of asked, and they were like, sure. So to all the people who complain about how hard it is to get access to commercial predictions. So how we're going to look at bias is not, there are many different ways to look at bias. And as some recent work has shown, not all of those things can be simultaneously satisfied. So not every algorithm can be, an algorithm cannot be unbiased in all the ways that you might want it to be unbiased. And so to sort through that, we're going to focus on maybe the most consequential result of the algorithm, which is who gets into the program that we're interested in. So these extra help programs. So we're going to be looking at essentially that as our kind of measure of bias. So here's how the algorithm is actually used in practice. every year or kind of maybe twice a year, so that in this case, the healthcare system has bought the software from the manufacturer, and that software lives on the healthcare system's cluster. And k times a year, the patients who are in the primary care practices, their data are run through that algorithm, and a risk score is generated. And so that score is then used as a screening mechanism for who will get into the program. And so if you are at or above the 97th percentile, you are auto-identified for enrollment into the program. So those people just get into the program. And if you're between the 55th and the 97th percentile, your data and some additional information are presented to your primary care doctor. And that doctor is essentially in charge of saying, yes, I think this person should be in the program or should not be in the program. So there's kind of a human in the loop for these guys between 55 and 97. And above 97, you're just in. And so what we're going to be looking at specifically is, for a variety of health outcomes that we care about, the average outcome for whites conditional on score compared to the average outcome for blacks conditional on that same score. And I'll tell you a little bit more about why we care about those outcomes in a second. So here's just some basic data about the population we're studying. There are lots of people, and the one we're going to be looking at first is what we're calling total number of illnesses. And so the way to think about this is that in a given year, you'll have a bunch of encounters with a doctor that are recorded in your, in the payment data. So like the insurance company pays for a visit, you go see your doctor, or you go to the ER, or you go to the hospital for a given medical condition. And there are a certain number of chronic illnesses that are very commonly used to measure how sick someone is. And so this is for things like heart failure, heart attack, diabetes, things like that. And those are bundled into this, kind of an index. And what this number does is it just looks at, in a given year, how many encounters have you had for one or more of those basket of bad things. That make sense? And so you can see, on average, black patients are sicker than white patients in our sample. What this graph is showing you is, on the x-axis, this is the percentile of algorithm predicted risk. And on the y-axis is that quantity. This is the total number of illnesses in a given year for people at a given percentile of the algorithm risk. And on the y-axis, we've separated out black patients versus white patients. So you can see that basically throughout the risk distribution, conditional on the algorithm predicted score, black patients have worse health than white patients. And so that's throughout the risk distribution. To pick an arbitrary point, we can look at that 97th percentile threshold. So this is the threshold where people just automatically get put into the program. And at that threshold, blacks are 28% sicker on that measure of sickness than white patients. And so is that a lot? Is that a little? We can actually kind of do a simulation to try to understand what that means and what the magnitude of that bias is. So what we're going to do is we're going to be working right at this threshold, and we're going to start with the white patient who's right above the threshold. So this is the person who gets kind of defaulted into the program. So we're going to take the least sick white patient, and we're going to take the sickest black patient who didn't get into the program, and we're going to swap them. And we're just going to repeat that exercise until the marginal patient has the same health. So we're just going to switch and switch and switch until we get two people who have the same health. And if we do that, we would actually double the fraction of auto-enrolled black patients in the program. And so this doesn't seem like a small amount of bias, at least around this threshold. And you can see it's fairly smooth at any threshold that you could pick. Okay, so that's kind of a global measure of illness in general. One nice thing about working in this electronic health record data set is that we can get a lot finer resolution. So this is a measure that's derived from insurance claims. So who knows what's going on in there. So we can actually start looking at biomarkers. So we have access to the patient's blood pressure over the course of the period that we have data. And if you look at the fraction of visits in a year where that patient's blood pressure was out of control, you can look at that too as a function of the algorithm risk score and race. And you can see that, again, black patients much more likely to have uncontrolled blood pressure. At that threshold, the blood pressure difference between blacks and whites correlates with a 12% increased risk of heart attack, 8% increased risk of all-cause mortality. So again, these are fairly large blood pressure differences. This is a biomarker that indexes the degree to which your diabetes is controlled, so hemoglobin A1C. Again, much higher in blacks. This difference at that risk threshold correlates to a 25 increase in all-cause mortality. And keep going. This is lung function. And we're just going down the list of all of the chronic illnesses for which we have biomarkers in the electronic health record. This is, anemia is a marker of chronic illness in a lot of different ways. So it aggregates just kind of sickness. It declines with age. And so at that risk threshold, again, the hematocrit difference between blacks and whites is about the difference you'd see after 14 years of aging. Kidney function, same thing. The marginal black patient at this risk threshold already meets the definition for kidney failure, whereas the white patient is far from it. So I'll stop. There are a lot of biomarkers on which black patients appear to be sicker than white patients, conditional on risk score. So I promised you mechanisms. So where is the algorithm going wrong? Well, one clue is where it's going right. And so here, this is the same risk score percentiles on the x-axis. On the y-axis is the average cost in that same year by black versus white patients. And you can see that those are looking pretty close. And so there are some small differences here, but overall these lines are much more overlapping than any of the lines related to health. And so you can already guess what this next graph is going to show. This is, rather than predicted risk on the x-axis, this is our measure of health. So this is the number of chronic conditions that you have, again, just kind of binned into percentiles. And you can see that whereas cost predictions are largely overlapping for black and white patients, these curves, the cost conditional on health curves, are quite different. And so in some sense, you can think of this as just a trade-off. Because of this different relationship between costs and health for black patients versus white patients, by definition, if you are predicting cost accurately, you will not be predicting health accurately.
This is the forward-looking chronic health
Yeah,
condition?
yeah, this is exactly for the next year. Yep. Okay. A couple.
What drives the cost?
Let me try to answer that in the next couple of slides, and then tell me if I haven't addressed it enough. So, if you just run a regression of cost on health and a dummy for like black and white, you get this. So it's about an $1,800 cost difference conditional on a given level of health. You can also, we have very fine breakdowns of the kinds of costs that are underlying that aggregate cost. And so you can see that black patients not only cost less, but they actually have very different kinds of costs. So in general, the things that are much less for black patients are, this is inpatient hospitalizations. Outpatient specialists is like, your cardiologist, your psychiatrist. Outpatient surgery is things like, carpal tunnel release, injections for knee pain and back pain and things like that. Interestingly, also fewer medications. So this is just like generic pharmacy expenses are less. On the other hand, actually, blacks have higher expenditures on things like dialysis and emergency visits. And so does that help give you kind of like a texture of what kinds of costs are contributing to this?
Is that driven by location, perhaps, and the cost of local hospitals and doctors, how much they charge?
Yeah, so It's probably not that, because all these patients are based in Boston and they're all in the primary care network of a single hospital. And so they might go to some different hospitals, but it's pretty centralized, and the hospital tries not to have people go out of their network.
So does it imply that the same operation on a knee would cause more for a wide than black?
Probably not. Probably not, because it's all in the same network. So I have some guesses. I don't have definitive evidence, but here are some potential drivers of this. So I should have mentioned, all these patients are insured. So this is either Medicare or pretty good commercial insurance. So it's not that people are differentially, seeking care because of differential insurance. At the same time, even with the same insurance, socioeconomic status doesn't just operate through differential insurance coverage. So there are all sorts of financial barriers. There's a lot of co-payments. Even without co-payments, there's transportation costs. There is a lot of logistical stuff, like people just have annoying bosses and have jobs where they can't get out of work for a day to go to their appointment. So there are just a lot of things that, because socioeconomic factors are correlated with race, there are those frictions that lead to people getting less health care. On the other hand, there are also probably some direct effects of race. So there's a really interesting randomized trial that was done in Oakland where black patients were recruited and they were randomly assigned to either a white primary care doctor or a black primary care doctor. And then their healthcare utilization was tracked for the next year. Overall, those assigned to a black primary care doctor had 18% higher uptake of routine primary care services. So this is things like, vaccinations, blood pressure screenings. And that was much, much higher when there was anything involving a needle. So like vaccinations or blood draws or things like that versus non-invasive blood pressure measurements. And this is a randomized trial. There's nothing else going on. This is just something about that doctor-patient relationship that's different for black patients when they have a black primary care doctor or a white primary care doctor. And I think that adds to evidence that was observational but really compelling around healthcare use by black patients before versus after the revelations of the Tuskegee study, and further away or closer to Tuskegee itself. And there were just enormous drops in aggregate utilization of medical care by black patients after the study was revealed. And so I think these are, if I had to guess about the mechanisms, this is probably the two big categories of things that I'd put forward. Okay, so to summarize so far, because the algorithm is predicting cost accurately, it is under-predicting health risk for black patients, which means that since that algorithm is used to screen for entrance into a program, it basically means that healthier whites are kind of cutting in line. They are getting ahead of less healthy black patients for this extra help program. And so the proximal cause is, of course, the choice to predict cost as the target. Yeah.
Quick question. So you said that all of your previous analysis was conditioned on the score that they were receiving. There's also a layer of doctor discretion.
Yeah.
Did you look for bias in that layer as well?
Yeah, we're actually like, that was a reviewer comment. And so so thank you. We're actually trying to build that in now. The short answer is that there are small differences in how doctors treat black and white patients that actually redress the inequalities in the algorithm. And so black patients are getting into the program at slightly higher rates than they would if it were just based on algorithm score alone.
But still not.
It does not appear to make up for the bias introduced by the screening procedure itself. Okay, so that's the proximal cause. But of course, the deeper cause is pretty interesting too, which is why was cost chosen as the target for the prediction? So there's I think an obvious story that I'll just caricature for now, and then we'll kind of go into it a little bit more deeply. But that story you could call the follow the money story. And that is that, sure, as a society, we care about health. But hospitals and insurers might cynically, privately care about just costs. And so actually that is the object of interest for the people who pay for healthcare and deliver healthcare. And in fact, this is a version of a very pervasive problem in healthcare, which arises from that difference. So the choice of cost in this case is privately optimal, but socially suboptimal. And so you could view this as, in some ways, the prediction equivalent of an externality, which is that this difference is not being priced in. And so a private actor is behaving in a way that distorts a socially valuable outcome, one of many in healthcare. And so you can translate that into a thought experiment, which is to actually, as distasteful as it may be, to put yourself in the shoes of a self-interested algorithm developer and imagine that actually you might be cynically making a trade-off. So you might be willing to tolerate a certain amount of racial bias in your predictions because you're getting better predictions of cost and maybe cost savings. And so that's certainly one possibility. So we're going to do a thought experiment where we're going to try to construct an algorithm that achieves those goals as well as the original algorithm, but is less biased. And so here's what we do. We very slightly modify the original algorithm, which is to say, first we rank by health, so those bins of health in last year, and then we rank by predicted cost. So we're basically in a bin of last year's health. We're ranking people by their predicted algorithm score. And then we're using that to create a relationship in a training set and applying that relationship to a holdout set. So I'll show you the holdout results, but it's clumsy, but it's not overfit. And here's what we get. So the original algorithm, so this is cost versus percentile of algorithm risk score. The dark blue line is the new algorithm. The lighter blue line is the adjusted algorithm. And you can see that it's actually predicting cost pretty well. And in fact, the R-squared is quite similar. But the new algorithm is substantially less biased. So this is the percentile of the risk score starting at 50. This is the fraction of black patients at or above a given score. And so at the 50th percentile and above, you're getting more black patients that would be screened into the program throughout that part of the distribution. And at the 97th percentile, again, to pick that arbitrary point, there are 61% more black patients at or above that score under this slightly modified algorithm than the original one. And so what we did, of course, was we changed, in a way you can think about it as just changing the objective function. So rather than pure cost prediction, we're kind of blending cost and health prediction in a very simple way. That reduces bias, and it doesn't seem to really hurt cost prediction. I don't think this is a general claim. Clearly, cost prediction beats not cost prediction in general. But all this is to say that there are other algorithms that we might have used that would behave similarly and be less biased, which of course brings up the question of why didn't the algorithm developer do this? To which I'd ask you, why do so many online ad algorithms predict ad clicks instead of predicting, revenue attributable to the ad? Yeah.
Go ahead, sorry. I'll let you finish that.
Okay. And so here's one hypothesis, which is that we've been thinking of one trade-off in this space, which is it's possible that the algorithm developer is just trading off racial bias in predictions for accuracy of predictions and cost. But there's actually another trade-off here, which I think is the more relevant one, which is prediction accuracy versus the cost of producing an algorithm that has a given accuracy. So, and by that, I don't just mean accuracy for predicting costs. You can actually imagine that cost in year t+1 is not really the object that we even care about. So you might care about the capitalized cost of a given patient over the period in which that patient is likely to be in your pool of patients that you're responsible for. An even better one might be not the cost itself, but actually the avoidable cost. So if I allocated this patient to this program, what would be my cost savings by treating health conditions that wouldn't otherwise be treated without that program? And so you can tell by how many uses of the subjunctive, is that the subject, that these are very hard objects to produce. So this is fundamentally a kind of fairly complex heterogeneous treatment effect question. This is trying to figure out who's going to be in my pool in year t+1, t+2, the costs associated with the health. So all of these things are actually quite difficult to produce. And if you're a data science team, you might well say, yeah, we're not going to do that. We're just going to predict cost because all these other things are just really hard. And so my second hypothesis that I would submit to you is not evil genius, profit maximizing corporate greed. It's actually just that this stuff is kind of hard. Even evil corporate, greed doesn't produce infinite resources for generating algorithms. And so the operative process here is actually that these teams are just learning how to do this well. Yeah.
So if you think about the effect that the program would have on cost, maybe just for next year,
yeah,
you don't think health status is a better proxy for that than cost in the future? It seems
Yeah.
like even that simple proxy is a better proxy.
Yeah, I agree. And let me show you one thing, and that I think is exactly your point. Here's the general version of it, though, is that the costs that the algorithm was originally predicting are actually a proxy for some underlying kind of complex target that, we can think of lots of different ways to specify that, but it's something related to health. And I think that's to your point. The program operates on health. The program doesn't just dial down costs. The program is fundamentally a health intervention. It's about getting you appointments and getting you medications. And so whatever we're interested in, it's something about health. Now, using cost to proxy for health is in many ways very logical because people with more health needs do on average have more health costs. So that actually makes a lot of sense. And it's a lot easier to measure. Like if you have a data set of insurance claims data, as Shreyas knows, it is a lot easier, since Shreyas did the original work as one of our RAs, it is a lot easier to get cost than any of these other things that he had to wrangle out of the electronic health record data set. And so in this view, cost was chosen not because of a privately optimal trade-off of bias versus health prediction, but just because it was pretty convenient. And because we didn't really think ahead to the consequences of that choice. Yeah.
These are super interesting stories. Just curious, how were these developed? Is this from theory or is from talking to the actual data scientists in the field?
You mean this hypothesis? Or
either one.
Yeah. So we talked to them, and I'll come back to that in a second. Okay, but first, I want to try to make the case that this is not just a particular problem affecting this individual algorithm or even this space of population health management algorithms. This is actually a very, very generic problem in health, but also in social policy more broadly, as Salon has actually, I think, started to show in a number of really interesting articles. So in general, health algorithms, but algorithms being used in policy more broadly, are basically complex data set in and label out. And so in medicine, it's like an X-ray read in through a convnet, producing a radiologist's interpretation of that X-ray. In our setting, it's patient's medical history as embodied in insurance claims data, predict cost. The formulation of that problem, what is the label, means that the choice of label is often done expediently rather than out of a deep, careful knowledge and infinite resources to pursue whatever deep, careful process is being undertaken. But that set of choices means that along with the rest of the stuff we're interested in, we can end up automating error and bias and incentives and inequalities and all of the things that we actually don't like about our healthcare system, along with the good. And so when you're automating a radiologist's interpretation of an image, you have to remember that radiologists have incentives to behave in ways that are not necessarily socially optimal. When you're operating with costs or diagnoses, you have to remember that there are structural reasons for which poor, non-white people are less able to access diagnostic resources, less able to take a day off work to get the test that they need to get something diagnosed. And so a generic way to think about this is that you have a target variable that you're predicting. And that target variable is some sum of y star, which is the true but unobservable underlying quantity of interest, plus some delta. Now, of course, we don't observe how much is y star and how much is delta, so we predict y. And if your predictor is any good, the expected value is just going to be the sum of those two terms, the expected value of y star given x and the expected value of the delta given x. And that gives rise to two potential scenarios. One is the good news, which is that if that delta is basically random, that's great. And you're actually going to do better in your prediction than in your observed variable, which is an amazing trick. So essentially, this is going to be your prediction y hat is going to be a denoised version of the thing that you really want to predict. And that's really cool. The downside is that if delta is not white noise, you're going to get in your prediction the sum of those two things. And what you're going to get depends entirely on the balance of the predictable element of y star plus the predictable element of delta. Now, we might worry about this because in general, I think you'd agree that this is all just about finding covariance. So the covariance of delta with x actually has scope to be a lot bigger than the covariance of y star with x. Why is that? Well, because y star is often really complicated. It's a biological phenomenon. It's overall health. It's avoidable health. Whatever it is, it's pretty complicated. Whereas the delta can be all too simple, related to age or insurance or race or sex or any of the things that we often record in our demographic variable set that also affect a lot of the problem that create a lot of the problems in our healthcare system. And so there are a couple general insights that I'll just go through in the last few minutes that stem from this very simple framework. One is that when you're evaluating how good your predictions are, so if we just take a simple loss function, the difference between y star and y is basically the covariance, but the difference between these two things. So you can write it as the y hat star minus y star and delta hat minus delta. Now imagine two algorithms, A and B, and A is actually better as measured by whatever loss function you're using, but let's take this one. Is that predicting better because it's fitting better to the signal or to the error? And so you actually, when you're evaluating the quality of your predictions, even your loss function is going to mislead you in these settings because predictors that fit to errors can look very, very good. And predictors that remove delta from your predictions could look very bad on whatever loss function you're using. And that's very dangerous because it means that it's impossible to diagnose the problem with your algorithm. The other general insight is that if you believe that this term ends up being non-zero, you're going to end up generically reinforcing inequalities that already exist. So in a lot of problems where we want to apply machine learning in social policy and in health, we're trying to allocate resources as a function of y hat. That's just a generic prediction policy task. And whether that's diagnostic effort or whether that's policies in our case for helping high-need patients, you're going to end up allocating more to those who have more to begin with. And so this is another very generic problem that stems from this framework. Okay, so to your question about how we got some insight into the process, I'll tell you a little bit about the epilogue to this story. This might have been very obvious to you, but it was not obvious to us, which is that we kind of were finishing up the paper and getting ready to submit it. And we started thinking that we should probably let the manufacturer know. And it was a little bit scary because we had an IRB and we checked all of the data use agreement stuff beforehand, but you never know what's going to happen. But on the other hand, we also just felt like to start a productive conversation, doing that in the headlines first is probably not the way to impact. So we just emailed them, and we were like, "Hey, you don't know us, but we found this thing with your algorithm." And this is a big company. This is like an insurance company that owns the analytics company. And so it was a little bit scary. And then in a couple of hours, we got an email back, and they were like, "Wow, this sounds like something we should talk about." And so, of course, the first thing they did was they got their data science team to make sure that what we found was also in their data, which it was. So they replicated the results on their, one of their data sets that they used to build the algorithm. And then their response was like, "Can you help us fix this?" And so they just wanted to work with us and figure out how to make this better, which is really cool. And so we are in collaboration with the manufacturer. I should say this also came up in the review process. I have no conflicts of interest. We're not getting any money from the manufacturer. They didn't have any control over what we did. In fact, this started off as a project to try to estimate heterogeneous treatment effects from those discontinuities in the score. Didn't work out. But that's why we originally got the data. And so we're working with that manufacturer to develop methods to essentially predict a basket of health outcomes rather than just predicting cost. And this is early days, but by a very simple fix to that algorithm, on this measure of bias, which is essentially at a given score, how many excess conditions do you have across the whole risk distribution in blacks versus whites? This was in their data set, the number of excess conditions in black patients. And on the adjusted algorithm, there are 84% fewer of those. So at least by that kind of rudimentary measure, we're doing a lot better. I think I saw someone had a question. Yeah.
Shouldn't have reached out to the FDA instead?
Weirdly, these are completely unregulated. So there are no applicable regulations that you would invoke to.
So they didn't break the law?
No. No. I agree with you. It's surprising. This is it's a very unregulated space right now, and the FDA is essentially not being very proactive about getting out in front of the way that a lot of algorithms are being used in health. For specific medical purposes, like interpreting X-rays, I think they're actually much better. But for these kinds of complex decision-making processes, there are no regulations that you would invoke to.
Why the choice of insurance health claims? Because it seems like in this sort of very complex ecosystem, there might be a lot of other measurements and signals and potentially something substantially more high-dimensional.
Yeah.
Would give a very different story here.
Yeah, it's a great question. I think that's also probably a convenience decision. So these are, if you had to pick a single kind of data that are available at every single, organization that pays for healthcare, it's claims data. Many healthcare systems don't have their electronic health records up online and in a way that's easily accessible without Trace to help. So, it's also a choice driven by convenience. Other questions? Okay, so I think overall, the way I'd code all of this is to say that once you recognize that your choice of proxy is just that, you can actually start learning how to make that better. And I think that's to your point. Yeah, I think there are a lot of things that have much less measurement error for the thing that we care about than cost. that are not as easy as cost because there's some data cleaning involved and there's stuff to do. But I think that to me makes that learning view more plausible than the kind of privately optimal profit maximization view. So I'll just say to end a couple of things about that modified algorithm with reference to some of the literature on the mechanisms of bias in algorithm. So there are a couple of things that are worth pointing out. The training data are exactly the same. So this is not a problem that there are not enough non-white people in the training data. This is the same training data, same composition, nothing different. And the predictors are also the same. So we did not have to take race out of the predictor. In fact, race was never included in the original predictor, as we learned when we were talking to them, precisely because they didn't want to create any racial bias in their algorithm. And we did not do anything like orthogonalizing all of the x's again, like nothing. The only thing we changed was the target of prediction. And if you think back to the measurement error framework, once you take the delta out, there's nothing for the x's to covary with. And so the only thing it's going to covary with is y star, not delta. And so I think that's it's an obvious point ex post, but I think it's actually, for me, a really optimistic view of ways in which you can do something about racial bias without having access to more data collection, without needing to do a lot of stuff to the set of predictors. It's really focusing on that choice of the label. Okay, so just to close, we found quite a bit of racial bias in a fairly widely used commercial algorithm. At the same risk score, blacks were less healthy and thus were less likely to get into this extra help program for their health. And the root cause of that was cost prediction rather than some more complex health prediction. And while it's easy to see how the original algorithm reinforced structural inequalities where patients who used more care would then be allocated to get more care, the modified algorithm doesn't solve any of those problems. We're not doing anything about the structural inequalities here, unfortunately, but the fix to the algorithm is built on an understanding of those forces and how they play out in data. And I think that's really, for me, the secret to working to reverse them is starting with that awareness. So I'll stop there. I don't know if we have time for questions, but very happy to take more.
So I'm trying to understand the differences in the cost, black versus white. Mm-hmm. Which seems to me a little bit, it's not potentially an algorithm problem, but it will lead to a question about how data feeds into your algorithm. So if the cost for blacks is lower, there would be an incentive for insurance companies to prefer to pay more for blacks, and therefore they would encourage more blacks to be treated.
Yeah.
On the other hand, the doctors seem to prefer whites because the insurance pays more money for the same procedures. So they would try to get more whites into their practice rather than blacks because the insurance doesn't pay enough. So they have this conflict of interests, right? Now, if you would collapse the price and make it the same for blacks and whites, would the algorithm, the original algorithm, work in the same way and give the same results as you come up with when you sort by health?
So I
because
think,
then you fix the actual problem in the society or in the insurance versus doctor conflicts, and it has nothing to do with the algorithm itself.
Yep. Yeah, and I think that it seems like, if I understand your question correctly, if the cost production function from health were the same for blacks and whites, we would not have a problem.
Might. I don't know,
we probably wouldn't have a problem, and I think that echoes a lot. Many of the work on kind of generic bias in algorithm is that if the base rates of the outcome are the same in the different groups, then that's the secret, is to fix the structural inequalities. So I think that in some ways I should think more about the conflict of interest point. The reason it's a little bit, I think you're right that there should be an incentive to cherry pick black patients, because in this setting, what happens is the health system is paid a flat fee per patient, and then if they do less for those patients, they keep the change. Whereas if they end up having to do more for patients, they lose money. And so your ideal patient, if you were profit maximizing, would be a patient who had a lot of diagnosis codes that you could use to say to the government, look how sick they are, but didn't actually use any healthcare. And so you're right that as a health system, they should be preferring to get these sicker but less likely to utilize patients, of which more seem to be Black. And I don't know if that's something that happens in real life.
I just had a clarification question on the last slide when you had enrich and scare folks, and I was wondering, like, you did not need to enrich the population. Does that mean you've no need to, like, bootstrap your 12% Black population to reflect the actual population, which it would not solve an inaccessibility problem, but might be more representative? Yeah, great question. So I think in general, one of the fixes to bias that's proposed in literature, or the diagnosis is, we haven't learned the relationship for the minority group. And so we actually need to not just kind of bootstrap, which wouldn't fix, as you say, wouldn't fix that problem, but you'd need to go collect more data and get new examples of that so that you can learn that relationship better. So,
I'm curious, I don't know if I missed this, but do you know if they had actually considered some of these more sophisticated targets, where they were like interested in estimating heterogeneous treatment effects, but they decided practically that even though it's what we wanted to do, we would content ourselves with this? Or was it something that you sort of inferred from your discussion? I'm just kind of curious how explicitly they engaged in this kind of cost trade-off.
Yeah, I think that on the one hand, a big priority for this company is investing in helping their clients get electronic health record data up and running. And so I think that on the one hand, I think they're quite interested in enriching the data. I think that they probably would have framed it a little bit differently than this. So I think that there is, not just at this company, but just, it's worth pointing out also that it's tempting to, I've been saying company, but the user of this algorithm is a non-profit academic health system. And so this is not just a mentality that's in the company. This is but the dominant mentality is cost prediction, because cost is just this very salient variable to lots of people in the healthcare system. And the assumption, to your question about, are they thinking about heterogeneous treatment effects? No, not at all. Not at all. There is just this very dominant assumption that the cost reductions are proportional. And so they would say, it's what the quote of why do you rob banks? Well, that's where the money is. It's like, why do you want to get these high cost patients into the program? Well, that's where the cost savings are. And the idea that the actual treatment effects are not proportional to Y is a foreign idea in this world. So I'd say, long-winded answer, but I think it's mixed. I don't think that their explicit plan would have been to come up with better measures that are closer to the real quantity of interest.
Just one very quick follow-up. When you proposed this new measure, did they immediately think oh, obviously we should have done this? Or was it something that they were oh, we never would have thought of this. This is completely different than the way we approach the problem?
I think it was, let's try it. And then when that reduced the degree of bias, I think ex post it just makes sense. Yeah. Sorry, you had a question.
Is there time?
Jake?
Awesome. Okay, great. This feels very much in the flavor of some of the work that came out of the recidivism scores and the outcomes.
Yep.
And if we just imagine that there's a binary desirable outcome here, which is that the person gets healthier, let's say, then it feels like there might be a disparity between the false negative rates. That could be another way to reframe this bias.
Yeah.
To look at the expected Y given race and health that you put up, it seems like an analog to that is that there's a discrepancy between the false negative rates. And I'm just curious if after all this, even though you approach the solution a different way, if you actually do end up getting equalized.
Yeah, it's interesting. I mean, I think I'd need to think about this, and I can't think this fast, so I need to write it out. But I think that the fact that we have miscalibration on this is one of these things that can't be simultaneously satisfied. So if you condition on the outcome and then look back and want equality, that measure of bias is incompatible with these calibration genre measures. And so I think that is just an algebraic trade-off that wouldn't go away. And so I think you just, you couldn't have both of those things. So I don't know which direction, if you wanted equal numbers of black and white in the false negative group or something like that, I'm not sure how that would actually work in this data set.
One more question?
So is it clear that this particular program, is the goal really to reduce cost in long term, or is it to, and if the goal is to reduce cost in long term, is it clear it was not achieving that? Because maybe just to be completely objective, if one race does use healthcare less, maybe that this does reduce cost.
Yeah, no, it's an important question, and I think there is probably a true underlying trade-off here, in the sense that you can't do everything for everyone, and there might well be true underlying differential predictability of Y star by race. And if there is, then I think that brings up exactly the trade-offs that you posed. I think that we're almost tackling a smaller problem, which is to say that, sure, there might be some underlying true difference between blacks and whites, but we're not even close to Y star here. Y star is probably something like, to your point, about the treatment effects. So if I targeted a person with this program, how much money would I save? For what it's worth, I won't go back, but when you look at the breakdown of costs by race, black patients have more spending on emergency visits, and that is exactly the kind of stuff that the program is meant to work against. So if I had to predict which way it would go if we could approach that true underlying quantity of interest, it would actually probably disproportionately favor blacks. And so anyway, all that is to say that I think the closer we get to the real underlying quantity, the prediction target, the more the real trade-offs kick in. But we're so far from the optimal now that I think there's a lot of room to just make improvements on many different margins.
All right. Let's thank Ziad. We'll have reception still out in the back, and you can grab him for questions that you didn't get to ask.
And I'll grab beer.
And he'll grab a beer.